Hi, everyone. My name is Lauren Sansing. I'm the academic chief of stroke neurology at Yale, and it's my pleasure to speak today with Dr. Raoul Nogueira, who's the director of neuroendovascular at Grady Memorial Hospital at Emory University, and to first congratulate him on the completion of the SHRINE trial, and have a couple minutes to talk to him about the design and the results and the implications of the study. So welcome, and thanks so much for talking with me.
Thank you, my pleasure. Thank you for the opportunity.
So I think the first question, perhaps to get us started, is to ask you to provide a little bit of context and background for the study and what you were hoping to accomplish.
I think one of the most important things to understand about the context of the SHRINE analysis as it applies to any study that compares direct or primary mechanical thrombectomy with bridging intravenous thrombolysis followed by thrombectomy. These data only apply to thrombectomy-capable centers that have fast workflow, including the immediate availability of the neuroendovascular team. Meaning, what you're going to discuss here does not apply to primary stroke centers or to thrombectomy-capable centers that don't have an optimal workflow, or in situations where the neuroendovascular team is not immediately available. In those circumstances, there is no equipoise or discussion. We must continue to provide intravenous thrombolysis to all eligible patients under those circumstances, right? So it's really a well-oiled machine, comprehensive stroke center. You're ready to puncture the patient. Should we skip TPA versus still do bridging therapy? That's the overall context of our research. Here what we did is, by now there have been 3 randomized clinical trials, all conducted in Asia. The first one to be presented was the SKIP trial. The second one was the direct MT, and more recently the DEV3 trial. What we did here is we did an individual patient level pool analysis of the SKIP trial and DEVT trials, and with the idea of improving the power and try to better understand the subgroup analysis of these trials.
Outstanding, and congrats again on getting this done and addressing this important question. Can we hear a little bit more about the primary results that you found?
So in terms of the overall population, had combined across the 2 trials a total of 438 patients. 221 were into the bridging group, and 217 in the primary thrombectomy group, direct MT group. The baseline characteristics were, as you would expect, very well balanced. The age was around 72, 73 years old. The NIH stroke scale had a median of around 16, 17. And the time from symptoms onset to puncture was around 180 minutes. So it's just around 3 hours.
And what did you find in terms of the clinical outcomes in the bridging versus direct to MT?
So our primary endpoint was the 90-day functional independence, and the rates were pretty similar across the 2 groups. Okay, essentially the direct thrombectomy arm had a 56.7 rate of MRS 0 to 2 at 90 days versus 51.6 with the bridging group. So a small difference numerically favoring the direct MT group. The adjusted odds ratio was 1.27, favoring primary thrombectomy. But again, the 95% confidence interval ranged from 0.84 all the way to 1.92. So there is still about around 15% chance that direct mechanical thrombectomy is not non-inferior to the bridging therapy. So you're gonna need more of the other bridging versus direct trials to kind of narrow this confidence interval a little bit more and provide a little more certainty that direct MT it's indeed non-inferior to bridging therapy. There were no differences in terms of MRS shift. In fact, the adjusted odds ratio there was 1.01. And when you look at MRS 0 to 1 and 0 to 3 at 90 days, again, 1.03 and 1.11 adjust odds ratio. So again, very, very similar. Moving on to safety endpoints. The rate of symptomatic intracranial hemorrhage was not different across the two trials. It was numerically higher with bridging at 9% versus EVT direct was 6.5, but again, very small difference with an adjusted odds ratio of 1.3 and a p-value around 0.50. Where you start to see more differences when you look at NPH, there you had an odds ratio of 1.62, being higher with bridging at 13% versus 8.8% with direct MT, and a p-value of 0.14. And the rate of any ICH, but here you are computing even those hemorrhagic infarctions, type 1, type 2, that we know are asymptomatic, and it's unclear whether they have any impact whatsoever on outcome. That was a lot more common with bridging at 39% versus direct EVT at 26% with an odds ratio of 1.86 and a highly statistically significant P of 0.04. Puncture site complications were also more common with bridging therapy at 4% versus 0.5% with the direct MT. There was no difference in terms of 90-day mortality.
Really fantastic data. I'm curious whether with the increased power, were you able to identify any subgroups or clinical biomarkers that would identify a group of patients that might potentially benefit from directed MT?
I think the way I look at this data now is that bridging IVT is neither dangerous nor is a panacea, right? So it's one of those things that we don't need to be so polarized about having a black and white, always give versus never give. I really think we have to depart from the concept, from the question, should we or should we not be giving IVTPH to all eligible patients who show up with an LVO at a thrombectomy capable centers, to actually ask a much more important question, which is who are the specific patients who you should versus should not give bridging therapy if they show up to a thrombectomy capable center. And we are pleased to announce some of the findings of our subgroups. It really looks that patients that had symptoms onset to puncture longer than 180 minutes, longer than 3 hours, did a lot better with direct EVT. And the P for the interaction between TPA, no TPA, and 90-day function independence was actually statistically significant for this particular term. So it looks like if you show up within the first 180 minutes in relation to the puncture, you should receive TPA, versus if you show up later than that, you may not benefit from TPA and potentially you're just getting more of the risks. The other group that showed as a group that may benefit from primary thrombectomy is the intracranial ICA occlusion patients, which makes sense. We know that intravenous thrombolytics are not particularly efficacious with intracranial ICA occlusions, with reperfusion rates typically less than 10%. So I think we could confirm in your analysis that that particular subgroup of patients tend not to do that well with bridging and may do better with direct treatment. There were other groups where you saw a bit of a signal, not as strong as these two other variables that you just talked about, the time to puncture less than 3 hours and the intracranial ICA. Those groups were the NIH greater than 15, patients with intracranial atherosclerotic disease, patients with atrial fibrillation, as well as those presenting with hyperglycemia. Those 4 patient categories, they probably do better with direct MT versus bridging therapy. But again, the confidence intervals are still pretty wide. We need more data to reinforce these findings and know if this is indeed the case.
So that actually brings me to the last question I was going to ask you, which is, now that you've successfully completed this analysis, what do you think are the next steps? What are the big open questions?
I think we have essentially two important topics here. One is how you understand this better, right? So how you understand bridging without a place better. And I think we will have a total of 6 bridging versus direct thrombectomy trials. We have the 3 Asian trials. We happy to see the results of Mr. Clean No IV presented in this meeting. Then you have the SWIFT direct trial and the direct safe trial being completed. So in the near future, you're going to be able to pull out these trials and hopefully get to more narrow confidence intervals, not only for the overall treatment, but for all these different subgroups, and try to tease apart who are the patients who should receive versus not receive IV TPA prior to thrombectomy in a comprehensive stroke center. I think that's one important topic for the future. The other one that will take a little longer is the fact that there is a lot of data suggesting that TNK is superior to alteplase, right, in terms of thrombolysis in general, and in particular in terms of bridging, as it was suggested by the Extend IA-TNK trial. So I think future trials will need to replicate what was done in these 6 trials, but using TNK as opposed to alteplase to see if you can get better results with TNK bridging therapy.
It's certainly wonderful to think back about how far we've come for patients with large vessel occlusions, and exciting to think about what we're learning and what we still need to learn. I just want to thank you for spending some time and sharing the results of the SHRINE analysis, and congrats again, and best of luck with the future studies.
Thank you. In the name of all SHRINE collaborations, we again grateful for the opportunity and looking forward to more discoveries in the future.